Okay, we are gonna review here some frequently asked questions about latent tuberculosis. First question is gonna be, what are the two tests available for the diagnosis of latent tuberculosis? Okay, before answering to this question, we have to keep in mind that the definition of latent tuberculosis is imperfect, and you may be wondering why I'm saying that the definition is imperfect. And well, it is because if a patient is exposed, he might develop active tuberculosis infection, he might develop latent tuberculosis, or he might be exposed and clear the infection. Well, we don't know with the test that we have available, which is basically the tuberculin skin test and the interferon gamma release assay for the diagnosis of latent tuberculosis. We don't know if these patients, in which of these three groups they are, because all of these patients are going to have positive tests. But we can, so in these patients, we can rule out if they have active tuberculosis by getting a chest X-ray. Okay, but we are still left off if we don't know if these patients actually cleared the infection, were exposed at some time and cleared the infection, or if they actually have latent tuberculosis. So this is why I'm telling you it is imperfect, but it is what we have. And so in any patient that we have a positive TST or a positive interferon gamma release assay and rule out active tuberculosis infection, we should treat him for latent tuberculosis. And what type of hypersensitivity reaction is in the tuberculosis skin test? Well, this is a type 4 hypersensitivity reaction. This is why it takes 48 to 72 hours to develop a positive TST. And here we have to keep in mind that the reading should be done at 48 to 72 hours. But if a patient presents, let's suppose, 2 weeks after the test with a positive reaction, I don't know, 12 millimeters, let's suppose, after 2 weeks, we still consider it positive. Otherwise, if he presents after these 2 weeks, he didn't came to the to his appointment and presents after 2 weeks but has a negative result, we don't take that as a negative. We have to repeat the test. Okay, this is important. Name some common causes of false positive TST. Well, one of those is basal Kelmic wearing vaccination. This is not usually done in the United States, but is common practice in underdeveloped countries. So anytime we are presented with a patient that's coming from one of the regions where has this common practice, we have to keep in mind that it is a cause of false positive TST. But it is also important to know that the BCG vaccination is commonly administered at birth, and usually when it is administered within the first year of life, it doesn't give us a false positive result. It usually gives us a false positive result when it is given after 12 months of age. But still, we have to keep in mind and ask the patients that are going to receive the test if they've been vaccinated. And if so, we might prefer using the interferon gamma release assay instead, which doesn't have this false positive in patients vaccinated. Another cause of false positive is exposure to non-tuberculous mycobacteria. So patients that live in endemic areas of infection with non-tuberculous mycobacteria, we might also consider doing the interferon gamma release assay instead of the TST. And why does the interferon gamma release assay doesn't have a false positive with these two circumstances? Well, this is because the third generation interferon gamma release assay has particles that are specific to Mycobacterium tuberculosis, which is different from the TST test where tuberculin is injected, because these particles are common to many other Mycobacterium that are not tuberculosis, and so this is why we have false positive test with TST, but not with interferon gamma release assay. What about two-step testing TST? Well, we don't routinely do it, but we should do it if we are going to do it in a patient that is going to be tested frequently, such as healthcare providers. And why? Well, this is because if we have a patient that was exposed to bacteria a long time ago, let's suppose 20 years ago, and we are testing him today, we might have a first negative TST test. And then let's suppose that this patient is a healthcare provider and we're gonna test him again in a year. This patient is gonna have a positive test after 1 year, and this doesn't necessarily mean that he was or he acquired the infection within this period, within this year. This means that this patient that was exposed, he got a false negative first test because the exposure was a long time ago. And when we administered the test the first time, we sensitized these cells that were previously exposed to the bacteria, so that when we have the second test, we have a positive, not because he had the exposure within this period, but because the cells that were dormant and we sensitized them with the first when we took the first test. So in patients that are going to be frequently tested, we should give this two-step testing, which consists of taking test one day, reading at 48 to 72 hours as we usually do, but again repeat the test after 2 weeks if they have a negative result, to see if they have a positive one due to this phenomenon that I just told you. And if the second is positive, we say that this is the baseline. We take the result of the second test as the baseline. So if it is positive, it means that it is a booster phenomenon. He had the exposure a long time ago and just tested positive for the second one because, as I said, the exposure was a long time ago. So I hope it is clear. As I told you, should be done in patients who are going to be tested frequently, and this is the booster phenomenon in these patients that had exposure a long time ago. It is important. Why do we wait 2 weeks? Well, because usually if we tested like about, let's suppose, 12 weeks, we might get a positive result, and if the test is obtained after 2 weeks of the first test, this might mean that the person did had exposure within that time. But if we test like 2 weeks apart, this means that it is a booster phenomenon, because it usually takes about 8 to 12 weeks to become positive after an exposure. So this is why we give this period between tests of 2 weeks. Okay. What are some of the available treatments for latent tuberculosis infection? Well, we have 4 available regimens, and all of the 4 regimens have been proved to be equal. None of them has been superior to any of the other. So we choose a regimen based on individual circumstances. We have a 9-month daily regimen of isoniazid, a 6-month regimen of isoniazid, which I believe this is the one that the World Health Organization recommends. We have a 4-month regimen treatment with rifampin, and we have also the isoniazid and rifampin for 3 months, once weekly. All of the others are administered daily. And as I told you, whether we're gonna give 9 months of isoniazid or 4 months of rifampin, it depends on the individual basis. Something that you might take in account is that side effects. If the patient is believed to be consistent with the treatment, we can give him a long course treatment. But if we don't know if he's going to come back to his appointments and he's not likely to accomplish the 9-month regimen, we might give him 4 months of rifampin. or if it is a patient that's taking many other medications, we might prefer give him isoniazid rather than rifampin, since it has a lot of drug interactions. Okay, and the next question is, which antituberculous drug is associated with peripheral neuropathy and what is the treatment? Okay, the answer to this is isoniazid. Why does it happen? Well, this happens because isoniazid interferes with pyridoxine metabolism, and so the treatment, now you know, is pyridoxine. Okay, and which patients should be given prophylactic treatment with pyridoxine if they are going to receive isoniazid? Well, this is patients at high risk of developing peripheral neuropathy, and this is patients with chronic alcoholism, patients malnourished, or patients with diabetes. These are the groups of patients that are at a high risk, and we might consider give them pyridoxine if we are going to start them on isoniazid. Which antituberculous drug is associated with optic neuropathy? Well, this is ethambutol. I threw this question in, but let's keep in mind that ethambutol doesn't form part of any of the regimens of latent tuberculosis. Okay, ethambutol is a drug that is given in active tuberculosis, but this is a frequently asked question, so I just threw it in. Next question, which class of antiretroviral drugs should be avoided in patients receiving rifampin? Well, as I told you, rifampin has a lot of drug interactions. One of those is with antiretrovirals, especially protease inhibitors. And why does rifampin has so many interactions? Well, it is because it is a cytochrome P450A3 inhibitor, which also metabolizes many other drugs. Some of them being either protease inhibitors, some of them being anticonvulsants, some of them being contraceptives. So in any patient that is going to be giving rifampin, we have to ask about other medications, and if it is the case that the patient is taking other medications, we might consider giving a higher dose or using another treatment for latent tuberculosis. Okay, here we have a case. It is a 45-year-old female patient that was diagnosed 4 months ago with latent tuberculosis. She was taking isoniazid regimen. She received her daily doses for the first month, and then for the following 4 months, she lost follow-up. She presents today to your clinic asking if she should continue the treatment for the 8 months that she is missing. What should you tell her? Well, your answer should be no. She can't continue with the 8 months that she was left, and she must restart the treatment. And why? This is why. Because patients that are assigned to receive the 6-month regimen or either the 9-month regimen, treatment can be continued where left off only if the interruption was for less than 3 months. This patient had an interruption of 4 months, so we have to restart the treatment, give again the 9 months of isoniazid. For patients that are receiving 3 or 4 month regimens, treatment can be resumed where left off if the treatment was suspended for less than 2 months. Okay. And finally, what group of patients should receive treatment for latent tuberculosis regardless of TST? Well, this is immunosuppressed patients and children less than 5 years old should initiate treatment for latent tuberculosis infection regardless of TST when they are exposed to a patient who is known to have active tuberculosis. Why? Because as we know, they have a depressed immune system, so they are at high risk of developing the infection when they are exposed. So if these patients are exposed, we should begin treatment regardless of their results. And also an important reason is because, as I told you, it takes about 8 weeks to for the TST to become positive. Okay, so these patients that are at high risk, we should begin the treatment, and what we can do is to begin the treatment after exposure, test them at 8 to 12 weeks, and if the test is negative, we can discontinue treatment. But if the test comes back as positive, we have to continue until completion of treatment. Uh, and that's it. I hope you find these questions helpful.